Hello everyone, I am Dr. Sanjoli Soni, Senior Resident from PGI Rohtak, Haryana, India. My today's topic is a comparative study of steroid injection with or without lignocaine in treating frozen shoulder. Frozen shoulder is a common term for painful stiffness of the glenohumeral joint, which is characterized by joint pain lasting longer than 4 weeks and a minimum of 50% loss in glenohumeral movement in all directions. Frozen shoulder is also known as periarthritis shoulder and adhesive capsulitis. Incidence of adhesive capsulitis ranges from 5 to 7% of the general population and can reach up to 20% in the diabetes. Recovery from frozen shoulder has always been thought to be always sure and may be confidently expected. Numerous researchers employing diverse therapeutic approaches have documented that a significant portion of impacted individuals get whole or almost total elevation of the symptom in addition to the full range of shoulder motion. Numerous therapeutic approaches have been studied, such as stellate ganglion block, physiotherapy, infiltration, bassinet radiation, suprascapular nerve block, manipulation under general anesthesia, local or oral steroid, and so on. This is not a concern regarding the best type of treatment, as different treatment have different effect in different sequences. Finding a safe, affordable method to lower the condition's morbidity is a crucial for developing nation. In this study, we aim to examine the effect of two different frozen shoulder therapy modalities using distilled water alone or an intraarticular injection of methylprednisolone combined with lignocaine on measures including pain and range of motion without the use of sonography or fluoroscopy. Material and method. After obtaining approval by the ethical committee, we included 112 patients of 3rd to 7th decade who were coming for treatment of spontaneous onset of painful stiff shoulder with restriction in the range of movement around shoulder, that is extension, internal rotation, flexion and extension, abduction and adduction, either all three or any two or without any obvious cause, with normal AP and lateral X-ray view, visual analog scale greater than 5 and shoulder pain and disability index score greater than 50%. Patient with pathology of glenohumeral joint, significant cervical spine disease, history of trauma of shoulder, local steroid injection in previous 3 months, physiotherapy of affected shoulder in the last 3 months, cerebral vascular accident, inflammatory joint disease of shoulder, bilateral frozen shoulder, thyroid disease, coronary artery bypass, prior surgery of affected shoulder, allergy to lignocaine, medical condition like coagulation disorder, diabetes and local infections were excluded. In the study, patients were randomly divided by check-in-box method in 2 groups. These procedures were carried out in OT so that monitoring can be done easily. After taking the written and informed consent, patients were taken to the OT and patient were positioned in sitting position with the back straight and arm on opposite shoulder. Under all aseptic precaution, posterior approach was used to inject the drug in glenohumeral joint. This portal was located 2 to 3 cm inferior and 1 cm medial to the posterior lateral tip of acromion. At this site, the attempt was made to pass through the posterior soft spot between the infraspinatus and teres minor muscle. A 26 gauge 1.5-inch needle was inserted in the site with the tip pointing towards coracoid process anteriorly. The index and middle finger were placed on the coracoid process to direct the tip of the needle intromedially towards the coracoid. When in the right direction, the needle faces little resistance in entering the joint. In group A patient, they were injected with 2 ml, that is 80 mg of methylprednisolone and 3 ml of 1% lignocaine, and in group B, they were injected with 2 ml of methylprednisolone and 3 ml of distilled water in the affected shoulder joint. The entry point was sealed with the sterile gauze. After that, half an hour of standard shoulder range of movement exercise regime was performed under supervision and advised to do it at home daily. Immediate pain relief and increase in the range of motion was observed and scored by VAS and shoulder pain and disability index score at every follow-up visit in the first week, third week and sixth week was noted. They were assessed for improvement in the vast range of motion and shoulder pain disability index score. The result of this study was the statistical analysis was performed with the SPS version 29 of the Windows statistical software package. The categorical data was presented as number and were compared among group using chi-square test. The qualitative data was presented as mean and standard deviation and were compared by student t-test. The probability was considered to be significant if less than 0.05. There were no statistical significant differences in the demographical parameters such as age, sex, ASA grading among the study group. In our study, left shoulder involvement was only 31% and right shoulder involvement was 68.75%, and both the group were comparable in right and left involvement of the shoulder. The mean duration of pain was 3.88 months in both the group, and differences in the mean duration of pain in both the group was non-significant. The mean duration of restriction was 8.59 plus minus 1.11 month in group A and 8.47 plus minus 1.11 month in group B, which was comparable in both the group. The mean was score was comparable in group A, that is 7.2 plus minus 0.75, and group B 7.29 plus minus 0.71 before injecting the drug. After half an hour of the drug injection at the end of the first week and at the end of the third and sixth week, the differences in the mean VAS score of group A and B was statistically significant, respectively 4.16 plus minus 0.68, 4.98 plus minus 0.94, 1.89 plus minus 1.32, 5.54 plus minus 1.01, 3.3 plus minus 0.5, 4.04 plus minus 0.74, 1.52 plus minus 0.66, 2.32 plus minus 0.88. The difference in the shoulder pain and disability index was statistically significant in both the group after half an hour of drug injection at the end of the first week and the third week and the sixth week. There was statistically significant difference between the two groups in all the parameters of range of motion after half an hour of drug injection at the end of the first, at the end of the third, and at the end of the sixth week. Frozen shoulder. It is an overused and inappropriate name given to most of the painful shoulder joint. True adhesive capsulitis or periarthritis shoulder is clinically identifiable as a disorder in which there is different mechanical restriction of active and passive movement. Frozen shoulder is a self-limiting in most of the cases, having high comorbidity. The characteristic of the population was like previous studies. Frozen shoulder is considered as a disease of middle-aged person between 3rd to 7th decade. It is usually affecting the woman, frequently involves the non-dominant extremities, and occurs bilaterally in as many as 34% of the patient. In our study, the mean age was 53.84 years with almost similar age distribution in each group. It was well supported by most of the previous study, like the previous studies with the female preponderance. In our study, female population was 59.82%. There were more involvement of the right side in our study, while according to previous study, the frozen shoulder affects in the non-dominant hand. The average duration of the pain in our study was 3.8 months in both the group, which ranges from 1 to 7 months, which was lesser than the study by D.Y. Bulgan et al. 6 months, in which the range was from 1 to 12 months, and in the study of R.K. Sharma et al. It was 8 months, ranges from 2 to 16 months. In this study, we have stated restriction as per previous studies documented loss of all activity and passive shoulder movement, flexion, extension, abduction, adduction, external and internal rotation. Internal rotation as an inclusion criteria for patient selection. In the study by B. Scheffer et al., average duration of restriction of movement was 8 months, ranges from 2 to 24 months. In our study, it was 8.53 months, ranges from 2 to 12 months. In our study, mean was of group A decreases from 7.2 to 1.15, and shoulder pain and disability index decreases from 82.1 3 to 27.16. Mean VAS of group B decreases from 7.29 to 2.32, and shoulder pain and disability index from 81.91 to 37.45. Decrease in the VAS and shoulder pain and disability index was supported by the study of Wen Cheng Hung and Simon Crit, and shoulder pain and disability index has significantly lower values with methylprednisolone and lignocaine than methylprednisolone and distilled water, which was favored by the study of A. Pandit et al. They used 2 ml of methylprednisolone with 3 ml of 1% lignocaine in group A and 2 ml of methylprednisolone and 3 ml of distilled water in group B. In both the groups, restriction in the range of movement was decreased after the procedure, but there was significantly greater improvement in the range of motion in group A with methylprednisolone and lignocaine. In a study, Marks et al. Explained that early treatment with intra-articular corticosteroid provided a chemical ablation of the synovitis, which limits the fibrotic process of the capsule. With the resolution of synovitis, the termination of capsular scar formation, capsular remodeling, and recovery of the range of motion occur, which was supported by the orthopedic and rheumatological literature. No side effect of methylprednisolone was seen as criticized by others because a small single dose of injection was used in intra-articular form, not systematic. In other study, Wei Chung Hung et al. Used lignocaine immediately before stretching or mobilization exercises, which effectively relieved pain during the exercise program that enhanced the effectiveness of physiotherapy. Lignocaine hydrochloride, the most widely used local anesthetic, is a reversible blocker of conduction along the small nerve fiber that carry the pain and autonomic impulses. The effect occurs within seconds and block lasts for approximately 60 to 90 minutes. Once the patient can move their shoulder, their fear and pain of movement also decreases. This improves compliance and result in better post-treatment outcome. Since physiotherapy is a prime modality of treatment, immediate pain relief is a major determinant for patient to carry out exercises. Clark et al. Reported that recovery was better with active physical therapy after intra-articular injection. In our study, stretching or mobilization of the joint was performed 10 to 15 minutes after intra-articular injection and half an hour of the standard shoulder range of motion exercise daily. Our finding was similar to the study carried out by A. Pandey et al., in which the average duration of presenting symptom was 10 weeks, but in a study with Christine M. Elris et al. Study that steroid been more effective in improving the quality of life, range of motion than lignocaine alone in patient of frozen shoulder. The cause behind the good to excellent result in almost all the patient in our study may be due to the using 2 best treatment modalities approved by the previous studies: continuous supervised physical therapy and regular follow-up and motivation of the patient. So the conclusion of this whole study is, we came to the conclusion that the individual with the frozen shoulder respond very well to methylprednisolone and lignocaine combined with the supervised physical therapy. The process are easy to follow, take little time, and are reasonably priced. It is our belief that not all patients with frozen shoulder will recover spontaneously even over a prolonged length of time. Thus, these modalities should be made available to all of them. Thank you.